Good morning, everyone, and welcome to our first of what we hope to be many webinars with free CME. And go ahead and click forward, Lindsay. Just to keep everybody on the same page, we are doing this. It will be an hour, and you will have an opportunity to do questions and at the end. But please feel free to go ahead and load those into the chat now. Anytime you have a question, and then we'll have a chance to go through them towards the end. As a reminder, you'll be getting a credit for CME for free, and we'll have the information for you at the end. We are going to be recording this so it can be loaded up on the webinar for you to get, or on the web so that we can place it there, and all future webinars will be on there as well. Any resources mentioned during today's call will be emailed just to the participants on this and then loaded on the web for at the LifeBridge site so that you can have those as well. I think that's it for this morning. So let's get going. Just a note for disclosures, none of the speakers have any disclosures to make. All right, this morning I'm pleased to introduce today's presenter, Mark Katz. Matt brings more than 25 years of health policy and advocacy experience in healthcare insurance design, state and federal legislation, and practice management, focusing on value-based payment models and improvements in billing, claims processing and payment, and medical practice health information technology integration and use. Some of Matt's previous roles include the Executive Vice President and CEO of the Connecticut State Medical Society and Director of Private Payer Advocacy and Practice Management Center at the American Medical Association. Matt previously sat on the board of the Physician Advocacy Institute, a national nonprofit that works to advance fair and transparent payment policies and contractual practices by payers in order to sustain the profession of medicine. Today, Matt will be focusing on the current employment landscape in Nebraska for physicians as well as nationally. He will focus on considerations prior to deciding on employment status with regard to burnout and well-being, and finally, components of patient delivery needing improvements in employment settings. Please join me in welcoming Matt Katz, and I'll turn it over to you, Matt.
Thank you, Dr. Schaefer. How is everyone today? I hope everyone is doing well. I'm just sharing my screen and I just want confirmation that people can see it. And is that a yes or a no? Yes, I see people shaking their heads. That's always a good thing.
Yes.
So the first question is, how is someone that deals with advocacy and physician payment dealing with also wellness? And that is because in my work, I have found that many practices, many physicians are in need of that assistance in order to effectively manage, lead their practice. And so we are going to be talking today about the national issue of physician employment and physician trends. Then we're going to focus on Nebraska in particular, which you all on the Zoom today will be the first one seeing that information in the country on what's happening specifically in Nebraska. We're then going to look at some perceptions of physician employment. We're then going to pivot a bit to burnout as it relates to that employment situation and some recent studies. Then we're going to talk about how to address some of that burnout. We're going to show a case study, and then we're going to open it up for Q&A. And I'm going to do all that in 45 minutes. So we're going to get started. And I just want you also to know that you have twice as many slides than what I'm presenting today in the slide deck that you will receive from the Nebraska Medical Association. So you have additional takeaways and materials to help you in your practice and moving forward in your careers. So the goals were identified, but I want to be very clear. We are going to look specifically at Nebraska for Nebraska physicians and how this impacts you. And then we're going to be looking at some safeguards and burnout issues and how to address well-being in your practice, or other employment settings. So let's just highlight and level set a bit on the market nationally. It has changed dramatically since COVID. Optum, which is a subsidiary arm of United Healthcare, is now the biggest employer in the country with over 100,000 physicians employed in one form or another across 2,200 practices in this country. They also employ more than 20,000 allied health professionals. Aetna CVS also employs a large number of physicians, close to 25,000 total clinicians, many of which are physicians. Evolence, which used to be Empire, which used to be Anthem, which used to be WellPoint, they change their name every few years, has over 40 ambulatory clinics. That's where we're seeing expansion. Where are we seeing pullback? Well, Amazon, Walgreens, Walmart, they all got into the physician employment game during COVID with thousands of employed physicians each, but they are all pulling back from that commercial market space. And those physicians are in need of places to go and to become employed to practice, because those facilities are not only changing hands, they're closing. Private equity is backing staffing services, with more than 100 of the national healthcare staffing companies now owned by private equity firms. Almost 390 hospitals are owned by private equity. I am not suggesting in any way that private equity is bad. I'm just highlighting the trends so that you understand what's happening in the marketplace nationally, and then more locally as we get there. PE firms, though, are starting to purchase more and more types of physician practices, and there has been some state and federal investigations and some oversight tied to some of these deals and relationships. Many hospitals have closed components of their hospitals, such as OBGYN. Others have closed altogether, many in the rural area. The one physician employee owned entity that is expanding is Kaiser Permanente out of California. Not only in California, but they've recently gone to the East Coast in North Carolina and Pennsylvania, and they now have 35,000 physicians employed, 25,000 of which are in California. Health Partners is also expanding in Minnesota and Wisconsin. And ambulatory surgical centers employed by physicians are expanding as well. So it's not just private equity and hospitals and health systems. There are some physician entities. The Physicians Advocacy Institute, which did most of these studies that I was previously on the board of, which Amy, you're the CEO of Nebraska Medical Association, now sits on the board of, has done most of this research. They are an advocacy organization designed and developed to help physicians and their patients navigate today's changing landscapes. This current study was done in 2024 with data as recently as January 1, 2024. So as we present this information, it's very current. The previous studies that have been done by PAI showed that by 2018, 44% of the nation's physicians were employed by hospitals or health systems, which is up from 25% when PAI first did its study from 2012. During COVID, this employment trend dramatically accelerated from independence to employment through hospitals, health systems, and other corporate entities. And by 2022, 74% of the nation's physicians were employed by some entity other than a physician or physician-owned practice. Current data out as of January 1 now shows that 78% of physicians who are employed by some entity other than physician practice. And this is national data, but we will show Nebraska. Just in the last 2 years, more than 19,000 physicians became employed by hospitals and corporate entities. That's more than, of course, all of the physicians combined in Nebraska, if you just look at the magnitude of that employment shift. Not that all the physicians in Nebraska transitioned, but just to look at magnitude and understand some aspects of that. Let's look at some key national trends. I like presenting these things in graph form, but I also provide some tables and information in the supplemental material. So we have over 500,000 physicians today employed by some entity other than a physician or physician-owned practice. That's up from pre-COVID of 375,000 physicians. So it's about 125,000, almost 130,000 physicians who's during the COVID period and shortly thereafter that became employed by some entity. But if you look at that trend line, it is bending back a little. It is stabilizing, but it did accelerate during COVID. To look at it a little bit differently, look at just the hospital and health system. There was a dramatic movement from July 2020 really to January 2023 of employment in the hospital setting during the what I would consider the heat of the COVID pandemic. But corporate entities also saw an increase, not as dramatically, but they did see an increase. It was a rise, but there does seem to be a bit of a leveling off. But 53,000 physicians transitioned to employment by corporate entities. And by that, I mean health insurers, private equity companies, mostly within this category. So we went from 92,000, physicians employed by these entities starting in January of 2019 to almost 150,000. I said million before, I'm sorry, 92,000 to 150,000 employed. So where are we? We're almost at 80% employment by these corporate entities and hospitals and health systems. And this is just another way of looking at it. 55% of the market is employed by hospitals and health systems. About 22 to 25% are employed by other corporate entities, and the remaining amount is employed by physician practices. Looking at it another way, you can see different parts of the nation and where it's being led, where there's lagging when it comes to this hospital and corporate employment. The Midwest, which is where we consider Nebraska. I grew up in Minnesota and Wisconsin, and my family's in Iowa, Wisconsin, Minnesota, Illinois. So in the Midwest, we lead the nation in hospital or corporate employment. And when it comes to percent of overall employment, we obviously then lead the nation as well. When it comes to corporate employment, non-hospital and health system, we lag the rest of the country. And there's two reasons for that. One, there's some different regulations in place when it comes to employment, but two, because there was such a heavy concentration of employment by hospitals and health systems in the Midwest, there wasn't much of a market for those corporate entities, where in places in the South, there was very little hospital employment. And so there was a large market open to those corporate entities to begin employing physicians. So you can see a significant difference in the type of employer, but overall not a significant difference in the overall percentage of employment. So let's look at Nebraska, which is what everyone's most interested in. Again, this is the first time anyone's seeing this information. This is Nebraska. This is Nebraska as of January 1, 2024. 66% of physicians employed by hospitals and health systems, 22% employed by independent physicians, going down from 36% pre-COVID. And you've seen a doubling of corporate employment, but it's still around 12.5%. So you've got low corporate, high hospital and health system, and a shrinking physician independence within your market space, which mirrors the national data, but this is Nebraska specific information. You look now at it a different way, hospital and health system, the national average at 55%, you are way above the national average for hospital employment, as we mentioned, but compared to the rest of the Midwest, you kind of meander around that Midwest line pretty consistently, so you're tracking like the rest of the Midwest. Other corporate, as we mentioned, you are lagging. By the way, I used red for the trend line for Nebraska because, I guess it's kind of the colors of the Cornhuskers. I don't know. Being a Badger and a Gopher, I hate to say Nebraska red, but it is the Nebraska red, and you're at about 12.4% of corporate employment. Midwest is a little higher at 17%. So you're lagging a little bit. And the national average is 22.5%. So you are below the national trend on these other corporate entities, those health insurer employment. Places like Connecticut, where I live now, it is the opposite. There's a lot of corporate employment, primarily health insurer employment. But this is your trend line here in Nebraska. Independent physicians, kind of the reverse of the employed. You're straddling the Midwest line, and you are above a bit the average. I'm sorry, you're above the Midwest. You're straddling the national average, with more independence than the rest of your colleagues in the Midwest. And this just shows the percentages. The Midwest is at almost 15%, or almost 85% physician employed, non-independent, and you're around the 78% that the national average is. So those are the Nebraska numbers compared to the rest of the country. The other thing I wanted to show you is there is a difference between specialty. So you have other physicians, radiologists, anesthesiologists, who have a much lower employment by non-physicians than the rest of the Nebraska market. Primary care also is below the national trend line. Everyone else is pretty much way above the national trend line in Nebraska. If you look at hospital employment specifically, all of your specialties are riding above that national trend. And then when you look at corporate, all of your specialties are riding below. Those surgical specialties are right at that national line. So you can see there is a distinction by specialty, which is pretty significant in Nebraska, more than other states that we've looked at. Most other states are all kind of smushed together when all their physicians and employment, maybe with one specialty outside the norm. You have a pretty big dispersion between 4% and 20% here. So you do have some differences and some distinctions going on in the marketplace. Let's switch to the NORC study that PAI did, looking at what does this mean? What are the perceptions? Now we know what the employment situation is. What does that mean? What are physicians saying across the country about that? Over half of physicians have reported that their employment transition over the last few years has resulted in reduced quality of patient care and a pretty significant erosion in clinical autonomy. And half of physicians reported a deterioration simply in their relationship with patients, mainly associated with the time of the visit and communication. So lack of communication, lack of time with patient has led to deterioration in relationship. Now, in talking to some other groups, they felt this should be like 90 or 100 or 95% would show that. But what this is showing is around half of physicians who have transitioned to in employment have a concern about quality and clinical autonomy. But that also means that half do not. So half feel that their transition and shift hasn't impacted. And we'll go through some of that in a little bit more detail in a minute. I'm going to look at care delivery, clinical decision-making, physician practice administration, and professional satisfaction a bit. And the slides that I provided you as a take-home, there's a lot more data going in much more deeply to all the various questions that were asked. I'm going to try to summarize here for the fact of time and the presentation. So let's look at care delivery. 58% of physicians felt that autonomy was reduced. The top impact overall that they felt impacted quality. And nearly 45% of physicians said it worsened their patient relationship. And it was, as I mentioned, decreased time with communication tied to patient engagement that was the impact issue. Clinical decision-making, asking questions in a different way. 56% said the cost of care impacted their clinical decision-making. And nearly half said that there were practice policies or incentives. These are either positive or negative incentives that led to adjustment in treatments that their employer had put in place. Again, autonomy comes in when talking about clinical decision-making, and nearly 40% said there was moderate or low autonomy. in making those decisions. 61% said that they had problems referring patients, particularly outside of their employer network or employer practice setting. And 70% said that the employers used incentives for physicians to see more patients. So patient volume was a driving force within this clinical decision making area and the loss of autonomy. Administration, more than 40% said that they were dissatisfied with their work-related issues, primarily with the lack of ability to engage in management and have administrative support. Though there was exceedingly high satisfaction in medical equipment, technology, training, the quality of those technologies, and the policies and procedures associated with that. So new equipment, new furniture, new devices, additional training led to improved quality of certain aspects of clinical care in that transition. Interestingly, more than half of physicians that were employed and had transitioned to a different setting said that they didn't even know how to resolve disputes within their workplace. And one thing I need to qualify is those 1,000 physicians that were asked this had transitioned from independent practice to employment. So we didn't ask anyone that was in independent practice these questions. We asked physicians that had transitioned to employment by hospitals, health systems, and other corporate entities these questions. But they felt that they had no awareness of what to do with a dispute within the environment that they now worked. Now, care path and employment trends. Most physicians, the majority of physicians, said that they chose employment because of government and private insurer reimbursement cuts. So the Medicare cuts that are happening right now that are being proposed and have been proposed the last few years where reimbursement has been stagnant or cut, and then commercial private insurer reimbursement reductions or lack of increases. 53% of physicians said that is the driving factor that caused them to transition to an employment setting. 60% said that their current employer required them to sign a non-compete agreement. And 44% of respondents, interestingly, said that they would join a union, which is a dramatic increase from previous surveys done nationally that showed that the level of interest of physicians was 5 to 10%. We're now, at least in this survey, at 44% interest. And many of these physicians indicated they wanted to retire early, and burnout was the reason for retiring early and the drive towards an interest in unionization. So what are some potential guardrails to consider when private equity purchases healthcare? As we said, there's been a lot of private equity health insurer purchase, and this goes not just for private equity, but health insurer. It's protecting physicians to ensure that the medical decision-making and autonomy of clinical practice is in the hands of physicians, not someone with a non-clinical license or approach to care delivery. Making sure that any business decisions that threaten the solvency of medical practices are reviewed, increasing some regulatory oversight. It's okay to have some oversight, especially at the stage of acquisition, to make sure that patients and physicians are going to be protected. And notice I said patients and physicians, because a lot of times today the review is at patient access, but has nothing to do about physician protections of continued employment, of physician autonomy. So making sure those are in place. Enhanced oversight of these transactions, especially if an insurer is involved, and making sure that the insurance side of the business, making sure the coverage side is not dictating the care side. Modernizing some federal and state laws, the inability of physicians to own certain healthcare entities like hospitals seems to be antiquated. If we have insurers and private equity owning practices and hospitals, why can't physicians, why can't other clinicians own hospitals? And then working with state policymakers to ensure that they better understand where this employment is going, why it's going in that direction, and making adjustments to those medical payment policies at the state and federal level to ensure that there's protections in place for physicians and patients. Let's shift to physician burnout. Probably the reason many of you are on the phone today, on the Zoom today. An MGMA, a Medical Group Management Association study, found 27% of physicians had a physician leave their practice in 2024 tied to burnout, not any other reason but burnout. It's a slight improvement from the previous year where it was almost 30%, but still 27% is high. 41% of physicians said that burnout was worse in 2024 compared to 2023. So while it's globally getting better, it's also getting worse for some physicians. 14% of physicians responded saying their organization was improving on burnout issues. That is way too low. That is not enough. But it's good to see 14% of entities are starting to address it, but we would like to see that at 100%, and 14% suggests we have a long way to go. An AMA study on burnout found that almost 63% of physicians in 2021 had experienced burnout. 2023, we're down, but it's still almost 50%. So again, some improvement, but we're still having issues. What physicians are impacted the most? Now, the good news is every one of the top 6 are seeing reductions in burnout, but they're still hovering around 50%. So we're doing better, but we're not doing great. In fact, I would say we're doing pretty poor, though we're improving, and we have a ways to go. And another way of looking at it, you look at some specialty differences, and dissatisfaction is pretty high. A lack of feeling of support from the employer is a major issue for those, and almost half of physicians are feeling that they're not well regarded within their practice setting, not by patients, but by their employers. This data does have some differences by experience, years in practice, and you do see higher burnout in the middle than you do at the beginning and at the end of careers. So those of you on the phone today, and there are many of you, on the Zoom today, that have been practicing less than 5 years, you have less feelings of burnout, more feelings of excitement in practice than some of your more seasoned colleagues. That being said, if you've been in practice for 20 years, you also have better feelings and less burnout. But still having 41% burnout when you have 20 or more years, again, means we have a long way to go, and we need to address some things because everyone is feeling burnt out, even though there's a difference by age. The job satisfaction, the same thing. Early on, higher job satisfaction, middle years, not as much. And then as you get more seasoned, a little more satisfaction. But just to put things in perspective, this job satisfaction used to be for physicians above 90%, and we're hovering around 70%. So we have a lot of work to do in those areas that we're going over today. Almost a third of physicians are considering stepping away from clinical practice. The highest intent to leave are primary care physicians, believe it or not. They're between 30 and 40% of an interest in leaving. Their surgical specialties and other physician groups have much less interest in walking away, but primary care physicians have a high degree of dissatisfaction with clinical practice and are the ones considering leaving the most. Almost 36% of physicians are talking about reducing their hours. That's down from the previous studies, but that's still almost 40% of physicians feeling like they need to reduce things. And why is that? Well, this is a big issue. Physicians do not take time off. And when they take time off, they don't take time off. So when 25% of physicians take less than 1 day a month off for mental health, well-being, and vacations, it's a problem. So even though we have close to 25% taking almost 2 days a month off, we have 25% taking 1 or fewer. So we really need to work on work-life balance. Physicians say it's their inbox, their emails, their compensation, and being able to get someone to cover their service while they're not taking time off. And even when they take time off, as I mentioned, they're still working. So we've got to work on separation, reduce stress, and recognizing that physicians, or having physicians recognize that if they are not taking care of themselves, if they are not focusing on themselves, they can't focus on their practice and they can't focus on patients effectively. So it doesn't do anyone any justice or any benefit when you don't take time for yourself. And it's leading to burnout. And work hours are still up compared to previous years. Physicians with 5 years out are reporting 60% work hours. This is not going down. It's maintaining at a high level. And one of the reasons that people cite are EMRs and the problem with EMRs and the amount of time they're spending with EMRs. So we've really got to work on that issue. What are the barriers? Staffing is a huge barrier, but I want to highlight prior authorization problems, problems with prescriptions, referrals, diagnostic tests, and payment are big issues that are leading to physician burnout. There's workforce issues, but then there is structural compensation, reimbursement, insurance issues that are impacting physicians and the time it takes to provide care to their patients, or time away from providing care to their patient that is still work time. Supporting, what can we do? Again, working on physician autonomy, medical decision making, stressing interoperability of EMRs. These things have to talk to each other. There has to be transparency. You can't be locked out of your patient's care because you can't gain access to the EMR information. The No Surprises Act needs to be fixed. It is there to benefit patients and also providers, physicians, and other clinicians. It needs to have some fix. We've got to work on prior authorization. It's a number one issue that physicians cite as causing an issue outside of payment. And then the Medicare fee schedule reductions and commercial reductions. We also have to clarify some myths. Physicians think they can't do some things because they're physicians. They can't own an ambulatory surgical center. That's not true. They can't participate in MSOs, IPAs. That's not true. Those things are successful in other parts of the country where they're having an effect, and in places like Nebraska, where participating in these activities. And then developing some state-based programs like LifeBridge is important, and other physician assistant programs that we're going to talk about in a minute. What are we doing? What am I doing working with practices, and what you can be doing? Work to reduce those everyday burnouts and burdens, team engagement, improve communication. I find communication across practices, across administrative to clinical is important. Addressing emotional exhaustion, giving people time off, stop the depersonalization. Nebraska Medical Association can advocate to ensure that insurers treat you like physicians and not a cog in their wheel. And we've got to stop doing the same thing in the physician practice. I believe everyone in the practice needs to have personal goals and be evaluated, not to punish, but to educate, inform, develop leaders, and reward. We've got to work and talk about the joy of medicine more. Physicians used to do that. They've stopped. There is joy in medicine, and we've got to highlight it, accentuate it, promote it, and reward it. And we've got to get involved. What does involved mean? Join your medical organization. Physicians who are involved, I don't care if it's your state, your city, your national, your specialty, and I would hope all of them. But if you join, you tend to be more engaged, and you have that joy of medicine. You're giving back. You're getting information back. Join, believe it or not, these networking social engagements, whether it's through your medical associations or just locally, book clubs, poetry reading, painting, photography. Again, recognize and reward those other aspects of a person's well-being within medicine. Volunteer, local clinics, national missions, medical schools. And one of the biggest things I tell every one of the physicians I work with is mentor, be a mentor. It's not just the mentee that is getting benefit. It is the coach. It is the mentor. If you have been out for 20 years, mentor that medical student, mentor that resident, mentor that young physician. It gives back to them, and it gives you sense of being and worth, and it really helps. And we've gotten away from that because of the change in dynamics of medical training and employment. we need to find ways to mentor and coach. And then leadership programs. Help yourself by participating in not just managing and management, but in leadership programs, true leadership. How to be a leader, how to develop those skills in yourself and others, not just in your practice, but in your profession. It's important to do that so that we have future leaders who understand these dynamics. Advanced wellness and well-being. This is what I've done in some practices to help with the burnout, to help with the transitions. We've started nutritional programs, healthy options, portion controls. Many of you may still have companies coming in that provide food for lunch to talk, to give a talk, to do those things. And I know we shied away from a lot of that 10, 20 years ago, but they're still there. But don't have them come in with the fried chicken. Have them come in with healthy options. Exercise activities, walking, stretching, even those exercise bands. Give people a break. Ergonomics. And it's not about that expensive $800 chair. A mouse, a little mouse, keyboard, or a phone ergonomically may cost you $3 or $4 more, but it provides significant benefit to your staff and yourself when it comes to those aches and pains. And I'll get to an example in a minute. So the case study, putting all this in place, what does this mean? Well, you've got to plan ahead. You can't just do it overnight. You've got to have buy-in. You've got to have administrative and academic clinical champions. It's got to be optional, but encouraged. Find incentives to get people to participate, but don't make it a requirement or you have people disgruntled and then it defeats the purpose. Group participation. One-to-one is good after, but group participation. Start off the workday earlier. Give people breakfast and then start the work actual practice day later so that there's some time. Bring in healthy options. It's amazing what healthy food does to a discussion, and everyone's mental health seems to be through their stomach. So giving them some good healthy choices. Try to do it in the office so that people don't have to go somewhere, different place to park, different drive in the morning. Try to do it in the office if you can, but bring someone in from the outside. I've brought in physical therapists, exercise therapists, specialist nutritionists into the practices. It's hard to have someone in the practice educate everyone else in the practice because you see and work with them every day. Bring someone in. It's low cost, low hanging fruit. It's easy to do. Make it informative, interactive, regardless of exercise level. Don't do anything too strenuous because the goal here is to get people engaged with each other, laughing and doing things together, but also working on themselves. Provide tools and resources. Every case, I've done this now about 10 times, exercise bands are really inexpensive. They're $5 to $7, but they can do a lot in the practice and you can do them throughout the day. Ebooks, exercise. Don't give someone a hard copy book that they're going to put in a drawer. Give them something they can put up on their computer and they can walk through and use during the day. In my practices, they provide 5 minutes twice a day for people to do these exercises, these stretches, to think about their nutrition, write down their nutritional goals, just 5 minutes twice a day. They all have ergonomic mouses that use the mouse and the keyboard. Again, low cost, maybe cost of practice another $100, $200. This is just an example of what we do in the learning objectives. So you see that I'm not just making it up. There's actually a designed practice process and program that we go through. It looks like a book, but it's an ebook. And these are the objectives. It's getting people up, getting them motivated, getting them engaged with each other, battling some common practice issues of bad backs, bad wrists. What does this mean? Well, we surveyed staff. It's important to survey and do feedback and report and repeat the program. After each session, we had opportunities for individual discussion and encouragement. And as I mentioned, we asked all of the folks coming into these practices to bring healthy meals, and they have. What after 3 months did this mean? Not a single workers' comp new issue, and all of those previous issues were eliminated. Absenteeism reduced. I can't say it was eliminated, but it was reduced. Complaints were down significantly. One complaint tied to back, wrist, arm issues. More crossover discussions between clinical and administrative staff. Soda was replaced with a bigger water cooler, so more water. Less food out in the lunchroom area, which was a great way to reduce some issues of overeating. We surveyed them, 95% positivity, 75% compliance with stretching and exercise after 6 months. Nutrition was 45%. So food and eating was down compared to the stretching. The annual survey for this first practice, and we've got a bunch of others through it, will be out next month so we can see what compliance is. There's also recognition that staff's performance and activity is really tied to this well-being and behavior. So for a few $100s, really, these practices are seeing tremendous financial benefit. And I know from an additional review we did that this particular practice is seeing 2 additional patients a day. So that's 10 a week. That's 500 a year. That is also revenue to the practice. You're helping reduce that delay in seeing patients, and at the same time, you're seeing a benefit financially back to the practice that more than covered the ergonomic mouse and keyboard and bringing in a physical therapist or a nutritionist for the entire practice. And remember, you're not closing the practice, you're just starting this earlier and then opening the practice a bit later so that you can adjust the work time, so you're not losing that time. And that 5 or 10 minutes a day that you're giving people to stretch, they're more than making it up for it with productivity. I've got a few minutes left. I want to go through a few other things. LifeBridge in Nebraska is working on confidentially protecting you, peer support and coaching, and cultural wellness. Those are all important aspects of this. And then here's some resources. The material on the studies I've given you comes from the PAI website, which I've provided you, and the Physician Foundation, some material there. Nebraska Medical Association has materials for you. The AMA has some of the other study material. And then, of course, LifeBridge has that material for you as well. So there's places for you to go for additional information. There are tools and resources that can help you in your practice. I know that this change in employment can be stressful and difficult, and it impacts you and your staff, but putting together and putting in place some small changes that help you and your staff with your mental health and well-being go a long way to improve satisfaction of your job and your profession, as well as your colleagues in your practice, and also do generate positive revenue for practices if it's done well. With that, I'm going to turn it over to Lindsay and Dr. Schaefer to see if there are any questions, and we can go through any of these slides, and you have a lot more material coming your way.
Great. Thank you so much, Matt. I appreciate that. We'll open it up now if there's any questions. He's shared a lot of great information. So if anybody has questions, either feel free to drop them in the chat or come off mute and be able to have a conversation.
Well, while we're waiting for a question, one of the things I will say is that the materials you get as a follow-up to this that Lindsay will send out has a lot more detail on Nebraska employment that goes into different areas as well. So you can look at some specialty information and some specifics on not just physician employment, but practice ownership, which is a little bit different, but the information is there as well. And it has additional resources for you. So what we went through today is about half of that slide deck for you to take home.
Yes, those will be shared out after.
Chris Elliott, I'm a former ER doctor, and I'm Chief Medical Officer for an insurance company here in Nebraska, Nebraska Total Care. A lot of your slides referenced corporate-owned versus hospital. Is that what you refer to, private equity?
So corporate is really mainly, Dr. Elliott, two areas. It is private equity and insurer. And it is very hard to differentiate corporate and insurer and private equity, though my understanding is there is a study coming up from another group that tries to parse it out further. We felt that we could not present it, at least currently, because we didn't have the best handle on how to break it up. But it is in a large part of that PE corporate, to be honest with you, is Optum United, because they have 90,000 physicians that they employ now. So when you look at that number of 150,000 physicians, they're almost 2/3 of it.
Sure. Very good. Thank you.
You're welcome. And I want to just stress, we're not saying it's positive or negative that these employment transitions are shifting, but we do need to make sure that there are safeguards for physicians and their patients, especially on the autonomy side. And some entities are much better than that than others. We only hear the negatives in the press, but there are some positives. There are some entities doing it right and making sure that there's autonomy and there's still that insurer or private equity involvement. We just have to kind of, I think, give people better roadmaps on how to make it work as we're transitioning.
It's interesting. I was just reading an article this morning about the cost of prescription medicines in the States versus Europe. Wegovy and Ozempic are like $60 to $90 in Europe a month, and here they're about $1,000.
Yep.
It's really our prescription medicines are just out of control, aren't they?
They're out of control, and you've got some of these entities that are pharmaceutically tied in or based, and others
Right.
that aren't. And so I think one of those things, Dr. Elliott, is better understanding what's driving what in those situations to make sure that patient care isn't being used as a driver for the pharmacy or the pharmaceutical component. And so you've got to make sure to separate that. But we have a number of issues in this country with our healthcare delivery system, some driving the employment discussion, some driving the general cost, and some driving technology. Some of our technology is better than the rest of the world, but we're definitely paying for it.
That's right. Yeah.
And you can get an MRI in this country much faster than in most any other country, but it costs more. And so and insurance premiums keep going up. Cost of providing medical care keeps going up. We've got to address that, but at the same time, we have to make sure physicians are well compensated so that we have physicians in those communities that have access issues and barriers. The rural areas of Nebraska, the rural areas of Iowa, and some urban areas in Connecticut and in other states where there's care delivery deserts, and we've got to work on that as well.
Yeah, there's still so many in our rural and what we call kind of frontier areas across Nebraska. And it's sad to see that slide about the primary care decreasing.
It
Need
is.
more and more primary care.
And I would like to see that physician-owned hospital restriction eliminated for doctors, especially in these rural areas where you don't want to see a hospital go out of business. But if you can't have physician investment from the community in those hospitals, no one else wants to invest. I mean, no one, whether it's an insurer, another hospital system, or private equity, is giving that rural hospital, 10-bed, 12-bed hospital, anything. But those local physicians may want to participate and tie in and be partners. But today, there's a prohibition against that. And so we continue to struggle in some of those communities where we could have a birthing center, we could have a hospital that maybe isn't a full hospital like it is today, but could provide some specialty care because those physicians are still in those communities. But without them tying further into the hospital, it becomes difficult.
Yeah, and if they have all that emotional as well as financial, equity in there, they're going to put so much better effort into it. I think that's great. Is there work on that going on right now?
There is work on that, and I believe Nebraska Medical Association is part of that work at the state and federal level to try to figure out, it was done at a time where there was a concern about physician ownership, but now I think that concern has gone away, and there's been some recent studies. In fact, if you go to the Physicians Advocacy Institute website, there's a study that shows that the physician-owned hospitals are actually less expensive for major services than traditional hospitals, and by a large amount less expensive. And there's also studies out there recently this year that talk about quality being the same or better. So if you need a cardiac service, an orthopedic service, an ophthalmology service, some of these specialized physician-owned hospitals are doing a much better job on quality and on cost savings and reductions than the others. So there's not only a general interest as physicians in having that ownership, but there is a care delivery reason, two of them, quality and cost savings, where there seems to be a benefit. But that first ever study was done by the Physicians Advocacy Institute and is on its website that shows those savings, which are billions of dollars if they opened up and allowed physicians, even pharmacists, and others to own those facilities.
Sure.
Other questions on the data? I know it may be shocking that across the country, it's almost 80% employment, where just a few years ago, 2012, excuse me, it was 75% independence. There's been a big shift, and it is surprising to some, startling to others. And we have to look at what that corporatization means and how to protect physicians who are feeling burnt out, feeling like they have that loss of autonomy, feeling like they don't have a say. I have actually met with some insurers and some private equity companies to talk about what they could put in place. Some of them are starting to reach out to medical associations saying, what do we need to do to make people happy? I mean, and a lot of it's common sense, but some of it is they just didn't have a firm understanding of how physicians operated in a medical practice, and helping guide them in some of that means you don't even have to go the regulation and legislation route if there's some understanding and willingness. Allowing physicians to participate in organized medicine is another big thing that some of these entities don't look at it as an advantage or benefit to them. Others do. And remember, it's a place where physicians get their leadership training, interact socially with their peers, understand better networking and referrals. So there's a lot of reason to get engaged. But historically, employment meant, the employer not paying for that membership. But that's changing too in a lot of places. And a lot of these corporate entities and hospitals and health systems are actually partnering with medical associations to pay for those dues, so their physicians, younger and more seasoned, can get that education and get that interaction. Otherwise, they become siloed, and it's really difficult. Any other questions, Lindsay or Dr. Schaefer or Dr. Elliott?
Matt, I have a question for you.
Yes.
Are there any places that are working well on the prior authorization issue? And are they done outside of like a value-based agreement, or where is their traction?
So it's interesting. There are some insurers who are doing it through value-based. You're absolutely right, where you have to participate in value-based before you get that. I don't like that you have to deal with the incentives if you're not ready to get prior auth, because that means a lot of practices who aren't ready for value-based are getting involved in it to reduce the problems with prior auth, but then they have financial problems and they may not have the right staffing. So I don't like that tit for tat one or the, but there are some states that have passed some legislation. Texas was one of the first, where they passed what was called a gold card legislation, where if you have demonstrated to each of the insurers you contract with a certain degree of competency in their processes of approval, and let's say it's 80%, you then, for that next 12 months, it's 6 months, I'm sorry, next 6 months, you are absolved from any prior authorization requirements for those services with that insurer. It is individual insurer based because they all have their different processes and protocols and procedures, but each insurer has to be able to demonstrate you've met that threshold or you haven't exceeded it, and you have an opportunity to discuss why you think they're wrong and appeal. But that is a program that has started out. In other states, they're not using the gold card at a percentage. They're just requiring certain or preventing certain services that are done at a high degree of success and approval not going through the process. So you don't have to get approval for a generic medication for someone who has a cardiac issue any longer in some places, because they've simply said if it's a generic brand for anything from cholesterol to this or that, it should be something that's automatically allowed unless there's fraud and abuse. And so those kind of specialty or service-based or medication-based prior authorization eliminations, prohibitions are out there too. But Texas has got the first gold card. Theirs is implemented. Other states have passed legislation, but they haven't implemented. One is coming up, I think, October 1. Pennsylvania may be October 1, where their law kicks in. They passed legislation. Texas has, though, however, and there is some federal discussions for tied to Medicare Advantage and limitations on prior auth, but it is a huge problem. Now,
Yeah.
there, just to be clear, there is fraud and abuse, and there is some
Right.
need for certain checks and balances, but many of these services that are prior auth have an 80 to 90% approval rating. So why not put in place some things that would eliminate those that are doing it incorrectly, but allow those doing it correctly to pass through? It would save a lot of time and money. The other problem is many insurers are starting to realize the processes, the appeals are costing them more than what they intend to do. So we've got to work, but some of this could be working together, not working apart. And then there are some insurers, some plans across the country are working with medical associations on spot programs. And I would encourage that in Nebraska too.
Yeah, great. Thank you.
I see we have a question from
Dr.
Dr.
Hamill, did you have a question?
No, I don't think so. Oh, sorry. I think I accidentally pressed the button.
No problem. Just wanted to make sure. Any other questions from the group? Well, I know we're coming up here on time. I did want to share one last thing here. Matt talked a lot about different resources that are available, and as he mentioned, LifeBridge is one of those that you have. LifeBridge offers free and confidential peer-to-peer physician coaching to all Nebraska licensed physicians. So you can call the confidential line that's listed here to be paired with a coach. I'd also like to acknowledge a couple of coaches that we have on the call today, Dr. Schaefer being one of them who spoke earlier, and Dr. Mark Davis is on here as well, who's one of our coaches. They are fantastic resources here locally, and you can see all of our coaches that are listed on our website. Also, following the passage of legislation in 2023, LifeBridge is the only program in the state protected under statute. So that means physicians are protected against discovery of participation in the program, and they're not obligated to disclose their involvement to any healthcare facility, hospital, medical staff personnel, accreditation organization, health insurer, government agency, or any other entity. And finally, this program does currently remain at no cost thanks to the generosity of our sustainability partners. So I just wanted to throw that up here to say thank you to them. And also for the CME, I'm going to drop the link in the chat there. Thank you for participating. You can fill out that brief questionnaire and get your CME certificate emailed to you. And with that, is there any final questions that anybody has before we let Matt go? And again, thank you so much, Matt, for your presentation. And all of the information will be shared out with everybody.
Thank you all, and I really enjoyed my time this morning, and I wish you all the best. And remember, it's what you make of it, and try to look for those resources that are available to you. Most of them are free or low cost, and those little changes go a long way in making you feel better, less burnt out, more engaged, and get involved. Whatever it is, get involved and participate. It helps.
Thank you, Matt.
Thank you.
And thank you everyone for joining. Have a great rest of your day.
Thank you.